Pneumothorax is the accumulation of air in the pleural space, potentially causing a partial or complete collapse of the affected lung. Pleural space is the cavity between a two-layer membrane made of the visceral layer lining of the lungs and the parietal lining of the chest wall that contains a thin layer of pleural or serous fluid that allows partial vacuum of negative pressure, creating surface tension or mechanical coupling, reducing friction and allowing adhesion of the lung and chest wall while still allowing it to slide. A mechanical coupling mechanism can be imagined like a slightly damp glass that sticks to a coaster it was sitting on. The precipitation formed on the glass surface creates the same partial vacuum, causing it to stick to the coaster but still slide. Pleural fluid works the same way. Pneumothorax can be large or small and can result from trauma, such as blunt or penetrating chest injuries, such as assaults, car crashes, etc., or spontaneously manifest in certain patients with either favorable physiology for pneumothoraces, bad habits like smoking, or related pre-existing medical conditions such as COPD, cystic fibrosis, and lung cancer, causing the creation and rupture of air blisters and blebs. Pneumothoraces can either be non-penetrating, which are closed, penetrating, open, and can begin tensioning. Penetrating pneumothoraces are traumatic and often referred to as an open or sucking chest wound, common with stabbing or gunshot wounds causing damage to the chest and respiratory structures, resulting in a hole from the outside environment into the pleural cavity. Contraction of the diaphragm will often pull in excess air that will become trapped, creating a one-way valve for air accumulation in the pleural cavity. This is similar to breaking a window in a warm house on a cold day. This will result in cold air rushing in. Closed pneumothoraces can be spontaneous or traumatic. Traumatic closed pneumothoraces are often caused by blunt forces resulting in broken or fractured ribs that can internally pierce the lung, allowing ventilated air to escape from the alveoli into the pleural cavity. Spontaneous closed pneumothoraces can also result from any underlying medical conditions or bad habits mentioned previously that would result in chronic deterioration to lung tissue contributing to air blebs. Tension pneumothoraces are often secondary to traumatic pneumothoraces and is where the intrapleural pressure becomes higher than atmospheric pressure. With every breath, the intrapleural pressure will continue to increase with no possibility of air exit, resulting in partial or complete collapse of the unaffected lung. Mediastinal shift can result, which is the deviation and compression of mediastinal structures such as the heart and trachea toward one side of the chest cavity. This can induce obstructive shock as a compressed chest cavity presses against the superior and inferior vena cava. This restricts venous return to the heart, decreasing preload, stroke volume, cardiac output, and blood pressure. Cardiogenic shock will also occur as the heart itself is unable to produce efficient contractions while under compression. The needle chest decompression, providing an exit for the air, is not administered quickly. The tension pneumothorax will lead to death. This is similar to blowing up a balloon inside a bottle, where the volume of the balloon or lung will not deflate until a hole is punctured in the side, where the bottle volume represents the thoracic space continuously decreasing with each breath. More likely to have a spontaneous pneumothorax with 7 to 18 per 100,000 compared to women, which is 1 in 6 per 100,000. In particular, tall underweight men between the age of 10 and 30 are at an even higher risk. Some clinical manifestations and signs and symptoms of pneumothorax are sharp chest pain, which worsens when attempting to breathe in, also possible chest asymmetry on the affected side, shortness of breath, a dry hacking cough, rapid breathing and heart rate, fatigue and lower levels of GCS from hypertension, bluish skin from hypoxia, and in cases of mediastinal shift from a tensioning pneumothorax, you can get tracheal deviation and jugular vein distension. You can identify a pneumothorax through a CT scan or a chest X-ray. CT scans are better in this case as they can even pick up subtle pneumothoraces.